beloved Dr. Professor Paramesh, who is always instrumental in organizing, come what may, one monthly seminar pertaining to health for us. So indirectly, he is keeping on hinting us that you keep on maintaining good health, be cheerful. So thank you, sir. And also extend my welcome to Sri Rajkishore Singh, sir, and also Pandit, sir, and all our colleagues who are here. So with this brief introduction, may I request Professor J. Srinivasan, sir, founder, chairman of the center, to say a few words about the center, and then hand over to Professor Parameshwar to introduce the speaker. Thank you.
Good afternoon. Welcome you all to the monthly seminar that Dr. Parameshwar organized. This is the fourth year, right? We started in 2001. So we've had a variety of speakers covering all categories of health issues related to environment. Today, I have one on tobacco. So I thought this advertisement, which was there in my student days, which most of you would not have seen. And student days, doctors, scientists, cricketers, sportsmen were all promoting smoking. Okay. So from there, we come a long way, but still, I'm sure there's a lot more way to go, because I asked Dr. Paramesh, I don't think the sale of tobacco has gone down in India much compared to, for example, US. So it's important that we hear more about the bad effects of tobacco. And so I would like Dr. Paramesh to welcome today's speaker. Thank you.
Good afternoon, everybody. I had a sincerely welcome you all for this monthly program. This month is the World No Smoking Day. This month, and to speak about highlighting about the topic, all forms of tobacco is harmful on our health, either smoking or smokeless tobacco, both of them. It increases the risk of various diseases and shortens the lifespan. Tobacco smoke increases the cancer, heart diseases, stroke, other vascular diseases, chronic lung diseases, what we call COPD, type 2 diabetes, fertility issues, visual and hearing loss. There is no safe level of tobacco exposure. And also, I just want to see this picture. Yes, sir. Srinivasan is a very well known, is a man scientist. He practices what he preaches. The carbon footprint, they said you have to do 2 tons per person per year. He walked from Malleshwaram to here for 2 kilometers. We both the doctors also, we practice what we preach, sir. We don't smoke, both of us. In addition to that, I think the landmark judgment came in Miami. It was in May 2001, where all the 3 major tobacco industries were fined $700 million, believe me. In addition to that, near $240 billion have been given so that all the states take away all the cases, individual cases. This is one of the biggest impact it has been done, sir. I think having said that one, we are going to hear some of these ill effects of all the healthcare issues from none other than my dear friend Murali Mohan B.V. And he's a senior consultant to Narayana Health, Bangalore. So he did his MBBS and MD in General Medicine, Bangalore Medical College, MRCP in Edinburgh. And after MRCP, he did a pulmonology fellowship in King's Cross Hospital, Dundee, in that one. And he is an expert in the lung diseases, specially treated rare conditions, asthma, chronic obstructive pulmonary disease, sleep medicine, cardiopulmonary resuscitation. 2 incidents I have to mention here. He's a man with values, updated knowledge, youngster, and he go for a new thing coming up. I think 7 years ago, as a chairman, we organized the Indian College of Allergy, Asthma, Immunology Convention from Patel Chester. I was the chairman of the organizing committee. He was the chairman of the scientific committee at that time. And he organized beautiful conference for 2 days and 1 day workshop. One of the speakers, the important topic, didn't come. So last minute, in the middle of the night, in 2 hours, he got up, made all the slides. That was the most appreciated topic. Believe me, sir. Very well. In addition to that, one of the case we had, this is the ITC chief. IT chief invited me to address the environmental. I said, the tobacco industry, I don't want to talk to you at all. I like to keep away from it because I'm the one propagating. I don't want to. Sir, we have changed also. We are at hotels and all this thing, business, drug pharmacy. Please attend. We don't have nothing to do with the tobacco. That's why I went there. I talked to his sister's son had a lung problem, a 20-year-old. And so he was, all the investigation been done, everything has been done. And they found, they couldn't find there's asthma not controlled, short of breath. He has a girlfriend he wants to marry next year. And Parmesh, I sent all over India, nobody has done anything like that. Sir, I stopped seeing the patient. It doesn't matter for me, you have to see, at least touch him, talk to him. That we feel very proud of it. I spent 1 hour going through all this thing. Only thing it hurt, made me think, I think I tell you, hemoglobin. From the childhood, he is maintaining the hemoglobin of more than 16 gram percent, just like a high altitude. And from the childhood, it continues to the same. Hematocrit, everything high. Why it is? There's some oxygen deficiency is there. You don't get it in asthma and anything like this. So it has to be something else. We have to find out. They have done the bronchoalveolar lavage, take the lung. They look for tuberculosis infection, but not other thing. That's why that case, if the youngster is there, pulmonologist, you go to him, he'll find out. I discuss with him. Yes, we found out it's alveolar proteinosis. That is the second case for me in my life. 3 cases, so 1 in America when I was a fellow, 2 cases here in India, and he managed it. 1 case, a 10-year-old boy, I used to send it to Mumbai to lung washing. Mahashur was there, Professor Mahashur, late Mahashur. And this child, this boy, we can do it in Bangalore. Put to the tube, 1 lung breathing, another tube, put 1 to 2 liters of saline, remove that one. Every 3 to 6 months, he has to get it done. That is a lifetime. So he diagnosed it here for us. I'm so happy for these incidences. With humility, whatever it is, quite knowledgeable, innovative, and he tries to solve the problem, not to create problem. It's a great pleasure to welcome you, sir. Over to you. Thank you.
So thank you for that very kind introduction, sir, and it's a pleasure to be here. If I'm getting too medical in my treatment of the topic, please let me know and I'll scale it down. Okay, but I'm talking to a group of scientists and I thought I should keep it as scientific as possible. One of the other instances that Professor Parmesh always tells me about is he once asked me to talk on a topic and I refused to because that's a topic I didn't know much about. So when he asked me to talk on this, I immediately agreed because this is a topic extremely close to my heart. It's also very close to a person who's close to my heart. My wife is passionate about tobacco cessation. She started the Center for De-Addiction Medicine in NIMHANS. And so this is something we've actually been co-authors of the WHO manual on tobacco cessation for doctors and dentists. So this is something I'm very close, that has been close to my heart. So things have changed since the ad that Professor Srinivasan told you about, but we've known for a long time that TB has been that smoking has been very bad. So King James Stewart, who was James VI of Scotland and James I of England, wrote this. He said, "This is a habit that is loathsome to the eye, hateful to the nose, harmful to the brain, dangerous to the lungs, and the black stinking fumes that come from tobacco, its nearest resemblance is of the horrible Stygian smoke of the bottomless pit of hell." You can't look for stronger words than that. And this was in the 1600s, 17th century. And it took a long time for people to realize that what he said was actually true. So if you look at tobacco consumption by gender in India, this is slightly old figures, but you can see that smoking and tobacco consumption, this is smoking and smokeless tobacco, increased between 87 and 2000. Fortunately, now the latest statistics show not a decline, but at least it's stable and starting to come down in certain age groups. This is again to tell you that men smoke more often, women chew tobacco, because for some reason smoking is looked down upon as, you know, not appropriate for women, but they can chew tobacco. And in fact, somebody who lives not even a kilometer as the crow flies from here once told me how she was disapproving of somebody from their community whom I'd mentioned without name, that she had quit smoking when she became pregnant and was accompanied by her husband who helped her quit smoking. Both of them quit smoking at the same time. And she says, look at the girls from our community, how bad they are, they smoke. And all the time she's talking to me with a big quid of tobacco in her cheek. So chewing tobacco is fine. Smoking tobacco is bad for women, which is why you're seeing this big difference. In specific populations, and I would want to call your attention to the last on medical personnel. This is fairly recent statistics. 9 to 32% of them smoke, and 8 to 15% of them chew, despite seeing the problems that I'm going to show you very soon. And this is the current level of tobacco. And one of the things that's obvious from what you're seeing, higher levels of tobacco use are in the northeast and central parts of India, which coincide exactly with the income of the states. These are the poorer states. Tobacco is more common among them. And that's a problem, an addiction that they can do without, because it takes away a huge part of their earnings and they end up spending more on health-related issues. So that's something we need to focus on. The better off states, you take Punjab, Haryana, you come down south, are actually experiencing less and less smoking, populations who smoke less, lesser sales of cigarettes, and slightly better enforcement of cigarette and smokeless tobacco use. But this is the worrying thing. 13 to 15-year-olds in and around Karnataka, again, you see a high level of smoking among them. And childhood smokers are the ones who continue to become adult smokers. And these are developing lungs. So if you hit the developing lung, Sir is the expert on that area, you are preventing proper growth and they end up with greater problems as adults. So when you look at the contents of tobacco smoke, there are more than 4,000 substances in tobacco smoke. Out of these, at least are 43 cancer-causing substances. And many of the others are harmful, even if not cancer-causing, things like acetone. And the BBC has come up with a very nice thing saying tar, which is used for paving roads, lead, which is used in batteries, acetic acid, which is in hair dye, and so on, telling you that substances you will normally look down on, you would not even want to touch, what these people are inhaling into their body very, very closely. But smokeless tobacco is no less. It's not, we always talk about smoking, but smokeless tobacco has a lot of contents which are very worrisome. And on the right, you see the pie chart where you're looking at carcinogenic substances as defined very clearly. So the group 1 are those which are definite carcinogens, cancer-causing substances. Group 2A are probably cancer-causing substances. Group 2B are possibly cancer-causing substances. And group 2B and group 3 are possible but not very definite. It still remains to be proved. So more than 50% of the substances present in smokeless tobacco, carcinogens, have definite proof behind them. So nicotine is the most studied substance in tobacco, apart from all the other things, and it is a very unusual psychoactive substance. And along with alcohol and coffee, it is the most widely used addictive substance. Probably coffee is. And we all just had, or most of us had a cup outside. Now, the average cigarette contains about 10 milligrams of nicotine, which is by the way a fatal dose if or taken all at once. And with each cigarette, you inhale 1/10 of it. And between 40 and 50 milligrams is a truly fatal dose. So you have to be careful. Somebody who smokes or chews tobacco is all the time ingesting or inhaling a poison. So knowing what are the substances that are present in tobacco, let's see what harm tobacco does. So if you look at nicotine addiction and continuous exposure to carcinogens, what you're seeing is whether you're using smokeless tobacco or cigarette smoking, carcinogens are a major problem. They get detoxified and excreted. But in the process, some of them also get activated, and that starts to affect the DNA. So DNA is supposed to get repaired, but if you persistently get exposed to these substances, it leads to miscoding, mutations, which lead to cancer. If not to cancer, a very badly damaged DNA can cause apoptosis of the cell breaks down. So you go from somebody who's just inhaling a little, somebody who's inhaling constantly or chewing constantly, and you get a constant exposure, you're much more likely to end up with cancer. So a lot of people started using e-cigarettes, vaping, thinking that this is safe. And we know that the cardiopulmonary effects of vaping are as bad, if not worse. And many of the things that were added, so you had this thing called Juul recently, which triggered off a lot of problems in teenagers. They ended up on a ventilator in ICUs because of vaping, causing damage. It produced something called ARDS, Adult Respiratory Distress Syndrome. Many died. And the myth that vaping was safe has been dispelled once and for all. So actually, vaping is banned in our country. So if you look at the contents, as I said, there are a whole lot of contents. Nicotine is just one of them, but it's what keeps you addicted. And one of the things I've heard, I've never been able to confirm it, is that the tobacco companies, in the process of producing a cigarette, actually the nicotine is mostly gone during the processing. But they put it back because that is what keeps the person addicted. Okay, so if you didn't have that, you wouldn't A, get any pleasure from the cigarette, and B, you would not stay addicted to the cigarette because nicotine is the addictive process. I'm not going to go into this, but I'll just call your attention to the last line of all. So you have increased cytokines, which trigger inflammation and keep inflammation going. The endothelial lining of every blood vessel becomes dysfunctional, and endothelial integrity is very important to prevent blood clots from developing, atherosclerosis from developing, and it also prevents the arteries from tightening up, which is what subsequently leads to hypertension, among other things, and also reduces blood flow to the different tissues. So that part, endothelial dysfunction, seems to be more and more important, something that's coming under the microscope for us. In addition, we know that there is rising levels of diabetes in India. And smoking worsens insulin resistance. So insulin becomes much less effective, insulin that the person produces naturally from the body, and predisposes to developing diabetes. Especially in somebody who's already diabetic, this is an extremely dangerous combination. And finally, of course, you have a greater tendency to clots. That means clots in the arteries leading to the heart, to the brain, to the blood vessels, but also in the arteries leading to the lungs and in the veins. So you have a prothrombotic state, you have a greater level of clotting all over. And that's what leads to a lot of the problems that people have. So I'm not going to go through this again. So not only does it initiate atherothrombosis, it leads to progressive progression, but also I'll call your attention to those things in bold. Nitric oxide generation of bioavailability comes down. And nitric oxide is what keeps the blood vessels open. It prevents them from constricting too much. So the problems that I mentioned with constriction of the vessels is worsened when a person smokes. And the next is oxidative stress. And we know that oxidative stress, oxygen-free radicals damage tissues all around them. Okay? So these are increased when a person has uses tobacco, especially smoking. But I'll call your attention again to the top of that. So there is mainstream smoke, which is active smoking, which causes a problem. But you also have side stream smoke, which others will inhale, and that is passive smoking. So those are two important areas that we worry about. It's not just the smoker himself or herself, but also the people around them, especially their families, and especially vulnerable children who get exposed to side stream smoke. And I'll come back to something called third-hand smoke later. Again, you have a lot of atherosclerotic effects. What you can see is what starts out as a normal endothelium and artery piles up into an atherosclerotic plaque, which leads to heart attacks. But it's more than that. Tissue damage occurs, and this is typically what we see in the lungs, which leads to COPD that Professor Parmesh referred to earlier. And there is fragmentation of DNA, and it follows two pathways. One is very appropriately called the Thanatos pathway. Thanatos is the Greek god of death. And those of you who are fans of the Marvel universe know that Thanos is the god of death, and he comes back and kills off the whole universe. So That's one pathway. The other is the classic apoptotic pathways. And this is the last thing that I wanted to bring out in the basic biochemistry and pathophysiology, that you have changes in the DNA, but you also have changes which are epigenetic changes, which through histone modification and DNA methylation changes and dysregulation of the microRNAs and later the small interfering RNAs lead to changes which can finally lead to tumor progression after tumor initiation. So you can have a lot of malignant changes happening thanks to tobacco. And something that we are learning newly, probably something that has not been paid enough attention to in science, but in the last 15 years or so, we are gaining an understanding of it, that the gut microbiome is extremely important. And you can see again that the gut microbiome changes with use of tobacco, both smokeless and smoking tobacco. And the gut talks to the lung. So we get lung changes also when you smoke, when you chew tobacco. And it may be initiated directly, of course, as I've just showed you, but also by altering the gut microbiome. But the gut microbiome, or dysbiosis, as we call it, has effects not only on the gut or on the lung, but also has effects on the brain. And that's something that is gaining more and more attention. So watch this space. It's been coming up in a big way in the last few years. So this horrible looking mannequin tells you what are the different problems that a person can have who is smoking. So this is a smoker's body, very different from the handsome doctor and actor that we saw Sir putting up in the ad. So to keep it simple, heart diseases, you can get heart attacks, you can get angina, which precedes heart attacks, you can get all of rhythm disturbance, which can lead to sudden cardiac death, and you can get changes in the blood vessels, which cause what's called peripheral vascular disease. And it's one of the most horrible things when people's blood vessels in the legs narrow. They lose initially part of the foot, then they have an amputation which is just above the ankle, then below the knee. So chop, chop, chop all the way up until they lose a limb. And it's associated with a lot of pain and agony. This is what happens in COPD, an area of which I am particularly interested. That's the normal looking alveoli on the left. And you can see how ragged it looks on the right, and the breakup in the different alveolar bubbles. So the surface area is actually reduced because a lot of these break up into one large opening. We call them bullae. And that obviously is one of the things that leads to difficulties in breathing and a drop in oxygen level. It has effects on aging. It accelerates aging. So you can see a younger person balding, and you can see the difference. That is a diagram. It's not an actual picture of a woman, but women who smoke, especially, you can make out the difference between a young non-smoking woman and a young smoking woman. It's not so obvious among men for various reasons, but women are much more susceptible to develop the bad effects of alcohol and tobacco, possibly because, you know, by and large, women are smaller than men in terms of body weight and body size. So you can see these differences very often in the skin, in the hair, early cataracts developing. In fact, one of the most effective anti-smoking messages in England was this thing called Action on Smoking and Health, was they had two women looking, you know, saying both these women are age 38. Guess which is the smoker? And there was such a clear difference in the faces between them. So you have a lot of oral lesions. One of our co-authors on this book that I was mentioning that my wife and I wrote is Professor Hiremat. He's an expert in community health. And this is one of his particular interests too. And he speaks about all the different kinds of oral lesions. And these are some of them. Gingival recession, which typically happens with old age. You know, you use the term, your teeth are growing longer. It's not that the teeth are growing longer, but they're more visible because the gums are receding. You can get tongue cancers as seen on the undersurface of the tongue on the right side. And then another in the buccal mucosa, that's the floor of the mouth. And in parts of our country, there is this habit of reverse smoking, very windy areas. They put the lit end of the cigarette in the mouth. And what you're seeing is that burn there and cancer surrounding it. This is in people who reverse smoke. One of the wards I walked through on the way to my respiratory unit is head and neck cancer unit. And these are some of the pictures that we see. This is not from my ward, but these are some of the pictures that you see in patients who have cancers of the oral cavity, head and neck area. And they're pretty pathetic because I've just had a patient who's had surgery, radiotherapy. Now, because the function of the tongue, which is so important in protecting the airway, is gone, whenever he drinks or eats, he's aspirating things into his lungs. Okay, so it doesn't stop with curing a person with cancer. There are a whole lot of problems that continue to occur in patients who've had the cancer, even if they've been cured of it. This is the peripheral vascular disease that I mentioned to you, parts of the digits falling off and leading to gangrene. And as I said, gradually chopping your way down. These are some of the lung diseases that I deal with: COPD, pneumonias, interstitial lung disease. And in children exposed to passive smoke, a whole lot of problems that I'll mention again. The lungs clearly are filled with tar. It's very interesting to see the lungs of a person who's donating a lung to somebody who's had COPD, is the end of their respiratory life. And they get a lung, the lung of the non-smoker who unfortunately died in a traffic accident, pink, spongy. And this is the kind of lung that you'll see in a person who's been smoking all his life, black looking things. And that's the points of difference that I was making. You can see not only the color change, but the difference in a very fine spongy structure of the normal lung as compared to the opened up areas in the emphysematous lung. And of course, there's a whole lot of organs. This is just actually a small list of the organs that are affected by cancer due to smoking. And that's an example of a person who's had the lung removed for cancer at autopsy. The one on the left shows it at the bottom. The second one, it is spread through the whole lung. You also have cancers in the kidney. This is in the urine collecting area of the kidney. In the stomach, you have ulceration formed, and you can start to see in, not very clear, but you can see this area around. There is a cancer starting in this person apart from those lesions. So those are stomach ulcers also. This is a non-cancerous ulcer. And the sad thing is also a lot of young men suffer erectile dysfunction. And this is very closely associated with smoking. And this is a nice phrase from Shakespeare, referring not to smoking, but to alcohol. He didn't know about smoking causes it, but it definitely does the same. It provokes the desire and spoils the performance. So I was talking about first-hand, second-hand, and third-hand smoke. I already referred to first-hand smoke as being what the person actively smokes. Second is from side stream smoke that others inhale. But the third hand is also very interesting because all these volatile substances that are present in tobacco settle down on tables, chairs, soft furnishings. And if a child comes and touches it, that gets transferred onto the hands. And a lot of these are carcinogenic substances. So it's not just the person saying, you don't come here when I'm smoking. He leaves traces of his cigarette smoke on, various objects around, and that can be picked up by others. Obviously, the effect of these things comes down as one progresses from first to second to third, but it is still a very significant effect. So here we see on the left side, adults who are second-hand smokers, who don't smoke themselves, never have smoked, have an increased incidence of stroke, lung cancer, heart disease, and reproductive effects in the women. They have diminished fertility. And in children, you have the sudden infant death syndrome, which has other causes also, including genetic. But one of the factors, risk factors, is the sudden infant death syndrome. Middle ear disease, so we'll be leading with that, apart from lower respiratory illnesses, including respiratory symptoms. And one of the first things that we ask when parents say, my child is coughing, is, do you smoke? Do you smoke? Do you smoke at home? So there are a whole lot of effects, but I want to call your attention to the last line, which says just 30 minutes exposure is enough to reduce coronary blood flow. So if a person is sitting with somebody else who's smoking, not smoking himself, and has heart problems, you can end up with greater problems. So it's very, very important to say, your smoking is harming my health, please stop, go out. And this is fortunately being enforced in India now. So the long-term effects are more worrying, that there's a 25% increased risk of heart disease and lung cancer. In adult non-smokers, it's a known cause of lung cancer and ischemic heart disease. A 72% increased risk of respiratory illnesses in children. Increased risk for new cases of asthma. Children who didn't have asthma are more likely to develop it. And of course, one of the closest connections is with middle ear disease. And this is what I said, tobacco smoke that clings to clothing, bags, skin, hair, can cause a whole lot of problems, including cancer. And I can't come to an institute of climate change, climate research without talking about the ecological effects of the tobacco industry. So here you can see on the left the huge problems that the tobacco industry poses to the world: water depletion, increased land use, fossil depletion, and greenhouse gas emissions, which are a huge number. So you can see that there are 6 trillion cigarette sticks. So if they made just $1 profit on each cigarette, that even 10 cents profit, the 700 billion that they paid out is still a small part of their earnings from tobacco. So the tobacco companies really should be shut down if we're going to save human lives. And while we can ban cocaine, we can ban heroin, we don't seem to have the political will to ban tobacco. And nicotine is a far more addictive substance than heroin or cocaine, for example. On the right, you can see the annual carbon footprints are also referred to that of Professor Srinivasan walking to reduce his carbon footprint. And you can see what cigarette manufacturing does, how much the carbon footprint of tobacco farming, and the leaf curing, which is usually done over time. All of them contribute hugely to the carbon footprint of cigarettes. And there are other things. The cigarette butts, it doesn't stop with the manufacture or the smoking. It carries on because the discarded cigarette butt has problems. So you can see that more than 1 million cigarette butts were cleaned from beaches and waterways. The second most common litter after food wrappers. 40% of trees at waste facilities were affected by lithium batteries, which are found in e-cigarettes, and a whole lot of other things. I'm not going to take you through statistic after statistic. These are all available. But trees are chopped down to make the paper in which cigarettes are made. There's a whole lot of e-waste that is generated. Water is used. And of course, there is global warming that's happening. So despite all of us knowing so much about this, how come people continue to smoke? And I told you how many doctors are smoking. Professor Parmesh will know 2 very famous surgeons, thoracic surgeons in Bangalore, excellent surgeons, brilliant surgeons, both died of smoking related causes. Both died of lung cancer. Both of them have cut open the lungs of people with lung cancer and taken them out, and yet they could not quit smoking. In fact, one of them I know used to go out in the middle of his surgery, smoke a cigarette, and then come back. Okay, so knowledge is not the only answer. So while we like to give knowledge, there's much more to be done apart from just knowledge, because tobacco is so addictive. And why is it so addictive? Because it activates the reward pathway by addictive drugs. So you have cocaine, heroin, nicotine, all working on the same pathway. Alcohol works later through the same pathway. And the same drives food. Hunger, for example, when you eat, you get satisfied. The same pathway is involved. And sex, the pleasure that one gets from sex, the same pathway is involved by tobacco smoke. So that's why it's so difficult to give up tobacco once you're addicted to it. When we say dependence or addiction, what do we mean? We mean there is a compulsive need to use the drug. We mean there's tolerance, which means that you start with 1 cigarette, you become 2, it becomes 1 pack, it becomes 2 packs, and so on. So over time, tolerance develops. You need more and more to get the same effect. The third is there is withdrawal, including craving. So when the person has withdrawal symptoms, they have to go out and smoke. And there is salience. Salience meaning it occupies every part of their day. Every thought of theirs is in some way bound up with this. Person is working and says, I spoke about the surgeon who was operating, goes out and smoke because he has that withdrawal and it is occupying. When can I leave this place, go out, get a cigarette and come back? In fact, my colleague, Dr. Ranganath, we work together, tells me that one of his professors used to be taking the attendance, and about halfway through the attendance register, he'd go out, have a smoke, come back, and then complete taking the register. So that's the level of addiction that causes. And the last point that I keep making, continued use despite knowledge of harm. And that is one of the most important features of dependence. And if you look at, of all smokers, 70% want to quit, 30% try each year. So it's not lack of trying, but only 2 to 3% actually succeed in quitting each year. And the figures in India are even poorer. In India, there are, at that time, we're talking about 2008, Dr. Prabhat Jha is one of the leaders in this area of tobacco epidemiology. So he did this case control study of smoking and death in India. And what he came out with is there are 120 million smokers in India. Now it's probably double that. Only 46% try globally, but in India, it's only 20% who try, less than half of the West. And in India, less than 2% successfully quit. And so ours are special problems, and ours need local solutions, because bad habits can even ruin good horoscopes. So how do I go about getting a person to quit? I work very closely with our tobacco cessation clinic, but there are 5 A's that we look at, and I'll take you through those so that those of you who have family members who smoke can think about what is possible with this. Notice I very carefully didn't ask who among you smoke, because that's something private to all of you. So the first is ask, then assess, advise, assist, and arrange. And I'll explain what each of these are. So first of all, you need to ask, and you need to ask at every visit. Do you smoke or use tobacco in any form? Okay, so you can't leave it to the doctor, because doctors forget. We have a busy OPD, people are shouting at you saying, I'm waiting for a long time. Sometimes we forget to ask. So it's not reliable. You need to make it a very systematic thing. And so one of the things we suggest is, along with checking BP and pulse rate and saturation of oxygen, the person who's taking these things should ask, are you a smoker, and tick off a box, or do you use tobacco, and tick off a box. The other is to put a sticker saying that this person uses tobacco inside, not outside, so others cannot see. It's a private thing after all. Now, if the person is a tobacco user, I also ask, when did you start smoking? How long have you been smoking, etc., etc. That is to get an idea of how much their exposure to cigarette smoke or other tobacco is. But it's also important, did you try to quit previously? How many times have you tried to quit? How long was your longest successful quit attempt? And why did you quit the last time? That's an important question to ask, because many people will tell you, I just gave it up one day. Why did you give it up? Oh, the doctor told me to. Possibly doctors telling people to quit is very useful. But the other is, they started to develop problems, or their child started to develop problems, and the doctor told them, your child is coughing because you're smoking. Okay, so that's a very useful thing. And the last thing, why did you start smoking again? Okay, and that's again a very, very important question that we need to ask. Having made that assessment of the person's smoking, we advise them to quit. And we say you have to quit. Every tobacco user, there are no shortcuts. Even a person who's had part of the lung taken out because of smoking-induced cancer, we tell them to quit. He has 6 months to live. We still tell them to quit, because it improves the quality of life for those 6 months. And this advice is made in a clear, strong, and personalized manner. Everyone is to that individual. So these are examples. I think it is important for you to quit smoking now, and I can help you. Cutting down when you're ill is not enough. You need to quit and stay quit of smoking. And then finally, that line, we can help you, because the message among smokers, it's impossible to give up. There's one physician who was in Sarashinagar, not very far, who was smoking in front of his patients. And apparently his constant line was, I have not been able to quit. Where are you going to quit? Forget it. Okay, so we need not have that nihilistic attitude. Then, of course, it is personalized. It's related to his or her current or health or illness. Point out that it has social and economic costs, and I'll come back to this, and point out that it has an impact on his children and others in his or her household. After that, you make the assessment. Is the person willing to quit? Because many people are not willing to quit. And if they are willing to quit, then you start to provide the intervention to help them quit. If they are not willing to quit, you then start getting them to think about quitting. And there are particular groups you must make this effort. Adolescents, I showed you how many children smoke. Pregnant women, pregnant smokers, very, very important, because it affects, incidentally, and this is a point I made in the conference that Sir was alluding to earlier, it affects not only the smoking mother, it affects her baby, the unborn baby, but it affects the grandchild, because it affects the ovary, the eggs in the ovaries of the unborn child. So that has effects unto the 3rd generation. Okay, so smoking for a pregnant mother is the worst thing she can do for 3 generations at least. Okay, so these are the stages that we go through. So if you look at the person who comes to you, they haven't even started thinking about it. They're in the stage of pre-contemplation. You want to move them into contemplating quitting. Then you move them into preparation to quit, take action. Then they actually quit smoking. You have to keep them quit of smoking. They're likely to relapse. And then you have to move them back into the same cycle again. Because as I told you, only 2 to 7% of people actually quit smoking the first time. And then if you talk to smokers, they'll tell you there are good things about tobacco. Okay, so we ask them to sit down and make a list. What are the good things about using tobacco? What are the not so good things about using tobacco? What are the good things about quitting? What are the not so good things about quitting? So that's the, and we ask them to make a list, sit with them, they make a list. And one of the things that happens is you may have to assist them with the list, but there is a huge list of things that are beneficial to quitting and huge number which is harmful about tobacco use. And a much smaller list. A lot of people tell you I'm more creative when I smoke, which is bunkum because a lot of non-smokers are creative too. But you can't say that. You have to be, on the same page as them. And these are some of the things. I'm not going to go into that long list. The last line is particularly important. Addiction is self-perpetuating. So then you have to assess the level of addiction of person. As I said, why they continue smoking, how do they quit, why did they fail in their previous quit and so on. And then ask them to actually calculate how much it costs them their cigarette habit. And I've had some patients who tell me, sir, I could have built a house with the amount that I've been smoking, and I don't have a house now. So we use a questionnaire called the Fagerstrom questionnaire. Some of those things are very, very important. So how soon after you wake up do you smoke your first cigarette? And the deeply addicted ones, first thing they do is stretch out, and before they get out of bed, they've lit their first cigarette. Okay? And there are people who find it difficult to refrain from smoking in places where it's forbidden, in church or temple, at the library. One of the amazing things about that, I don't know if you've come across it, sir, is people who are heavy smokers and drinkers. During the month of Ramzan, the Muslims don't drink or smoke, many of them, and they don't seem to have any withdrawal symptoms. I don't know why. And the same thing happens with people who go to Sabrimala. These are people who've been smoking 11 months in the year. That 1 month, somehow they're able to just quit. So there is something more to spirituality than, we can't dismiss it. So this is something I like to always point out. There are only 2 levels of addiction, low and high addiction. There is no addiction based on the score. Okay, so somebody who's a smoker or a tobacco user, there's also a smokeless tobacco questionnaire, Fagerstrom adapted for smokeless tobacco use. Everybody who is a tobacco user is addicted. It may be a low level of addiction, but it may be a high level of addiction. Then there are many reasons for failing a previous quit attempt. And these are 3. There's a triangle we talk about. There's a behavior angle to it. There's a psychological angle to it. And there's a physical aspect. The physical aspect is the withdrawal symptoms that develop and the craving for the next cigarette. The psychological is a little more problematic. As I said, when they feel that this is necessary for them to calm down, they got into a fight with the wife, they got into a fight with the boss, they need to take this to calm down. And the other is the behavioral thing, where the act of holding a cigarette is something that is very pleasurable to them. Okay, so all 3 have to be tackled, and we need to find out which is the most important part of this. So symptoms of withdrawal usually begin within a few hours, increase over 3 to 4 days, and then start to decrease over 1 to 3 weeks. So it's still possible. The hunger and the craving for cigarettes can last 6 months or more. I had one patient who'd quit for, I think, 5 to 6 years. And then one day he was walking down the street and he saw somebody smoking on the other side. And suddenly he had this intense craving, went out and got a cigarette and started smoking again. Okay, so it's something as little as that can trigger off a relapse into smoking. In fact, my tobacco cessation colleague psychiatrist says, sir, don't call it relapse, call it a lapse, because we assume they are on this thing of improvement. They've lapsed once, they can always come back to the track. Okay? So this is what I was referring to as rapid fire craving, the previous one. So let's not go into this, but a lot of people have difficulty in concentrating and they feel very depressed. And there's a good reason for that, because nicotine is an antidepressant. It works on the cholinergic system, which is very important as an antidepressant. But you don't need to get into this. The problem is people who are already depressed feel a little better when they smoke. And when they try to quit, their depression worsens. When their depression worsens, their motivation comes down, including the motivation to quit. And that's why it's very, very important to start people on antidepressants and handle that part of it while you're trying to get them to quit tobacco use. So I'm going to skip this, but this is the second line is very, very important because there's an increase in appetite. Nicotine is an appetite suppressant. Nicotine also destroys the smell fibers, the receptors in the nose, and destroys some of the taste buds fibers. So the person cannot smell as well and taste as well. So food doesn't seem very attractive to them. When they quit, soon their smell and taste senses improve. And now food tastes good, smells good, so they tend to eat more. So one is their appetite improves, and also food is tastier. So they tend to overeat and put on weight. So that's something we take cognizance of when we're telling them to quit and say, look, you are likely to put on weight. Please be proactive, because you don't want to exchange one form of addiction, smoking, with another, which is food addiction. And more importantly, while smoking is the greater risk factor, you don't want to put another minor risk factor there. Okay, so unfortunately, smoking doesn't kill instantly like a gun. So we need to assist them to quit smoking. And there is a variety of approaches. I'm not going to go into that, but it's self-help tips going all the way down to pharmacological interventions. The physician has a lot of time to do. The more sessions we spend with them, and the more time we spend in each session, the more successful we are. And then these are the important things. We ask them to set a quit date, and it's usually not immediately. Don't say, as you walk out, stop smoking, because it takes some time. They've got to prepare for it. So they set a quit date about 2 weeks later, and we start them on either nicotine replacement therapy or other forms of pharmacological intervention, which start to have effect in those 2 weeks. Very, very important to tell family, friends, and co-workers, because you'll need assistance. I told you about rapid fire cravings. We just tell them to take what is called a 5-minute timeout. So you say, you want to smoke now, just postpone by 5 minutes. And this is something their friends can do. He says, no, I need to go out and smoke. He says, let's wait 5 minutes. I'll come out with you in a short time. Okay. And very often in those 5 minutes, the craving disappears. Okay. So the other problems are the symptoms that I told you about, and the fact that many people have told me they've lit up without even realizing that they have lit up a cigarette. So this man has full stress. He reaches into his pocket, pulls out a cigarette and is lit up. And about a few minutes later, he says, God, I had actually quit smoking. So he should have no tobacco products. We also advise them to throw away their lighter or matches. So they have to go hunting around to get a light to light their cigarette. Okay, so they need to avoid smoking in places where they spend a lot of time, where they're likely to be tempted to smoke. Okay? So I'm not going to go into this, but these are the things that I mentioned. Nicotine also helps the bowel movement. So when they quit smoking, quit tobacco use, they start to get very constipated. And a lot of people tell me that they can give up all the other cigarettes, but the one just before they go to the toilet in the morning is very important. So you've got to give them something else: fiber, water, laxative. As I said, anticipate weight gain, never buy a pack of cigarettes, never store cigarettes and lighters together, and always take a 5 to 10 minute timeout to avoid that craving. Many people ask me, can I continue to drink while I smoke? And it's very important that you tell them no, because the same places where they drink, there are a lot of other smokers. And in the presence of other smokers, it's difficult to give up. The second is alcohol reduces your willpower. Okay, so you got a strong will and say, no, I'm not smoking, but alcohol reduces it. And then, as my wife likes to say, will's power is more strong than willpower, and they start smoking again. And this is what I mentioned. Giving up smoking in partnership helps others to quit. Okay, there are various support groups. There are supports that psychiatrists offer. And there is pharmacotherapy. We use several different kinds. The first line pharmacotherapy is more successful, and it can double or triple the likelihood of successful smoking. But a combination of counseling and pharmacotherapy is essential. So a lot of people just say, I'll buy some nicotine gums and I'll start it. It doesn't work very well. Have to combine it with counseling. And more people are using CBT, cognitive behavioral therapy. So important thing is, many patients still require multiple attempts at quitting. And I'll show you this, but all smoking cessation strategies work, and they usually work better when you combine them. So every single strategy works. And you can see overall, whichever you're using, if a person is adherent to treatment, as opposed to those who don't adhere to treatment, your likelihood of quitting is more than doubled. And also, there are various costs. Tobacco cessation is probably the single most cost-effective intervention for people with heart disease. You can see that if you look at the effectiveness and the costs, if you look at statins that we use, it's the most effective. In terms of, on the bottom, you see cost per year of life saved. The best is brief advice to quit smoking. It's the most cost-effective way. But all the drugs that are commonly given, the statins, aspirin, are much more expensive and save much fewer lives than quitting tobacco use. But over time, many people quit. But you can see that when people take no action, the dark blue bars, they will quit. Every year, more and more people quit. But if you give them medication, it improves quit rates at every stage. And if they have behavioral support along with medication, quitting improves even better. At all stages, patient education is critical, and positive feedback is very, very important. And we always say, if you quit for 6 weeks, reward yourself, buy a shirt. If you quit for 6 months, maybe this game you wanted to buy, you can go out and buy if it's a young person. So everyone loves a quitter. We arrange follow-ups because lapses are common. So you need to offer follow-up, support, and you can monitor using various different chemical routes to make sure that these people are not just telling you I've quit, they've actually quit. So I'll leave you with these 5 key messages: ask, advise, assess, assist, and arrange. Okay, so there are some 5 R's which are the roadblocks to quitting. I'm not going to go into that. I'll stop at this point. Thank you all for a very patient hearing.
It is a wonderful talk, and also concluding with the 5 A's. It's quite important. Any questions, please?
So, I don't know if you know about forced delusions, in the sense that during COVID, most of the doctors were like, you have to be 6 feet apart. And these are part of forced delusions by the doctors themselves. You understand? It's coming from the doctor. And there are many such instances, for example, a seating arrangement or a parking lot. These are examples of forced delusions that you are put into every day. How will you metaphorically point out such a forced delusion without using the idea of smoking tobacco? You have an idea of how you can metaphorically say that?
I'm not sure.
Delusion, right? I'm telling that it's from the doctors themselves that you have to be 6 feet apart. So that was a forced delusion. Similarly, there are many other forced delusions.
No,
so how
I'm going to actually take issue with that. On that, this business of 6 feet. There is very clear evidence that the further apart you are, and 6 feet seems sensible to maintain some kind of social contact and yet reduce the risk of infections. We see it all the time. Okay, it's been repeatedly shown that very close contact increases the risk of spread. I'll give you one example. In the West, especially during winters, colds and other respiratory infections are far more common. Why? It's not because the weather is cold, because cold actually improves immunity. On the other hand, you have people who are huddled together in smaller places and spread infections between themselves. In summer, they tend to be outside. They are playing, they're in open areas. The risk of interpersonal transmission comes down. So I dispute that, saying it's a forced delusion. It's a lot of anti-vaxxers who come out with this thing that anything that science says, that an intellectual says is wrong, because Mr. Trump knows best what is good for you, Mr. Kennedy knows best what is good for you. That's not a forced delusion. I would trust a scientist who's actually done the work, and I've looked at it. There are good papers showing that. I have a paper where a person was seated in an aeroplane, open case of TB, and you can track the distance from him increases. As the distance increases, the probability that a person develops TB infection from him came down. A very nice hit. During COVID, we had the same thing. People who went to a Chinese restaurant. One half of the Chinese restaurant had very close to where the buffet was spread. People who went there had a lot of infections compared to people who were far away, and in between the two, there was an air conditioner which was blowing air, like an air curtain. No infection came in this group, who were separated from the other group at makeup. So I don't think this is a forced delusion. I don't think it's a delusion at all. But if you tell me that there are delusions that tobacco is harmful, is that what you're implying?
No, I'm saying that society works in a way wherein that you are expected to follow certain norms. And many of these norms are delusional and are not based on any proper scientific fact or knowledge for
That's
that
true.
matter.
That I don't dispute.
These are hidden from the public perception as such. It is not given a very thought out answer.
Professor Srinivasan showed you that thing in the beginning where doctors were also buying into the thing that cigarettes are good. Okay, so there is there are various forces at work that cause these things. I don't think it's a deliberate attempt to say, sometimes it is deliberate, people are manipulating something. But I think we make too much out of these. Most advice that is given has a scientific basis. If there is something you think that does not have a scientific basis, you're in one of the premier scientific institutes, go out, investigate and tell us, no, this is wrong. The 6 feet rule is rubbish. Masking is rubbish. It's up to you to prove it. But hitherto, we have good evidence that those are genuine, scientifically based. I think we should, until you can prove something different, we should follow this.
Okay. Any other questions? Yes, sir.
One very strange layman question. I had a good friend of mine, a very close batch. He's a continuous chain smoker. He's my senior colleague in my old office. 90 plus. Till he was below 90, at least to my knowledge, he was smoking 5 packets a day. After 90, still he is continuing 1 packet per day. Absolutely big. Is this his body got immune, or is just because
so we know that
no disease, nothing.
one of the slides that I showed had a genetic component. Okay, so there are some people who have great DNA repair mechanisms. One of them, so they don't develop cancer. There are others. One of the things we look at, both for interstitial lung disease and others, is look at the telomere length. Those who start out with short telomeres, and this is related to the enzymes that regenerate telomeres, are very different from person to person. So you have some families which have short telomeres. They develop a lot of disease of accelerated age. Hair turns grey very soon, skin wrinkles, teeth fall out very early, the lung becomes fibrotic, heart disease occurs, they get liver damage. So these are people who have short telomeres. There's another group who have long telomeres who actually, unfortunately, are more likely to develop cancer. Okay, so there is obviously an optimum length for each of these. But there are some people, coming back to your question, who are resistant to the effects of all the abuse the body throws at them. Most famous example is Winston Churchill. He smoked like a fish, he drank all the time, you never saw him without a glass in his hand. There's this very famous picture of him, one of his official photographs, taken by this chap called Yusuf Taj, who was a brilliant photographer. So he's posing for the photo, and he had this cigar in his mouth. And Taj went up, took the cigar out and threw it aside, and then took the picture. And this man is glaring at him, captures his spirit exactly. He managed to avoid significant damage to his health for a long, long time. Is everybody that lucky? No. So about 50% of people we know who smoke, even small amounts, are very susceptible. So I have a paper, not my own paper that I didn't put up, I hid it because it shows that even between 1 and 4 cigarettes a day, there is an increased risk of COPD, lung damage. There's an increased risk of lung cancer. There's an increased risk of all-cause mortality, not just lung cancer mortality. So even low-dose smoking can cause problems. Low-dose tobacco use can cause problems. Some people are extraordinarily lucky.
Yeah, that's what. I still see this
Yes.
is
Yeah, you're absolutely right. The problem is we should not look at these outliers.
Yes, sir.
Why do you think government is not banning cigarettes? If not cigarettes, because there's a lot of money involved. They can ban these 43 cancer-causing substances. Why aren't they?
That is virtually impossible to take all those things out. Because cigarette is a very convenient way of delivering tobacco. For example, a pipe, you have to keep relighting it. The same with cigar, for example. People have to keep puffing at a cigar to keep it lit, otherwise it goes off. The cigarette is the only one, because the paper allows it to continuously burn. So even if you don't puff on it, you leave it there, it burns its way down. So there are a whole lot of additives to cigarette tobacco that keep it lit. So either you have to ban the cigarette industry, or as I told you, they refuse to take the nicotine out. So for example, you have decaffeinated coffee, that's fine. You don't have denicotinized cigarettes, that's the problem. So why don't they ban it? They don't ban it, as I said, because there's a huge generation of revenue to the government. But you look at direct costs of tobacco-related illnesses, I'm talking about figures. I have not got the recent figures, but I think it's about 12 years ago or 13 years ago. The expenditure of the government was about 27,000 crores per year on tobacco-related bills, direct tobacco-related. We're talking about, not talking about indirect. The earnings from revenues, tobacco revenues, is about 25,000 crores. So actually, they are losing out. Okay? And they refuse to see it because this direct revenue is coming to the revenues department. The outgo is spread over various departments. I think that's one of the reasons they don't want to do it. There's no political will. Same thing with alcohol. They've succeeded in reducing the amount of alcohol, but you see, where has alcohol ban ever really worked? Let's just come back at you.
To answer that question, we have. Please sit down, sir. Please.
Yes, sir. Come on. Come to me.
I think we didn't have the data, Indian data, tobacco habits, what percentage of people smoking, anything like that. We used to quote WHO, say, that country, this country. It took 7.5 years for us to collect all the data, different population. I think we presented the data 2001 to S.N. Krishna, Chief Minister. And the same day, he announced banning the tobacco smoke. Karnataka, the first state banning the tobacco smoke. And 2003, Supreme Court judgment came from our study and all this thing. And also during that time, we went to the ladies' club. Ladies' club is small population, 60 people were there, ladies were playing cards. And would you believe nearly 30% of the smokers. And they used to only 555, imported variety. The working husband, spending wife was there. And they also take alcohols. He said, why do you want to smoke? Because it makes us to concentrate. This is the answer we got it. I think we banned it. And also, I being the past present Century Club, started by Bharata Saram Vishwesvaraya, they're the first social club in the world we banned the tobacco smoke. This is all things are there. We have to continue to do this one. And also, we had one thoracic surgeon, Jerry Mascarenas. I think you're talking. Yes, referring to. He was working with us. We are at Lakeside House. We were working with a thoracic surgeon. The most famous, all over the India, people used to come. Any surgery, he has to be. He did a mitral valve, first one, he did it. Even the thoracic surgeon, he did heart surgery also. He is so famous. And also, he had a lung cancer himself. But still, he was sitting next to my room. He never quit smoking. I went to his house and all this thing. Parmesh, this I cannot live it. He died from the lung cancer and the secondaries in the brain and all things. He died. In addition to that,
I'll just add to that.
Yeah.
The reason cricketers in India are so rich these days is indirectly due to Jerry. His son Mark Mascarenas is the person who started the professional management group, with Gavaskar being the first, and then a whole lot. There are now all billionaires thanks to Jerry's son.
Jerry.
He was my senior in school.
Oh, sir. Recently, I met his wife, also Jerry's wife. So, anyway, and in addition to that, you mentioned about it. Third, the smokers, third-hand smoking, that's something, and also ovary involving next second generation. These are all the two things we have to propagate this one. So that's another thing and mentioned about it. And tobacco butts, you considered. I agree about that, tobacco butts. So many things are right. And as a matter of fact, nearly tobacco butts, plastic-related issues. It is contributing. Nearly 24.6% of the oceanic debris, the tobacco butts, they go from you smoke, throw it out, and goes to rain, lakes, rivers, and the ocean. And nearly it has got cigarette butts has got 160 chemicals, and nearly it takes about 10 years to eliminate completely from that. So that we have to educate the society. And one thing you mentioned about it in a later when I wanted Scotland. In the first slide, it came there and other thing. Scotland is also known for golf. Golf, sir, there is a golfer. How did the word golf came? Do you know? This came out 200 years, over 200, 300 years ago. So, gentlemen only, ladies forbidden. Yes, that is G-O, LF means. That word came from that. So, I think I'm a member of both the golf clubs. We have ladies playing there. The national thing, we got a new membership for them. I think these are all things start from Scotland. In Scotland only golf started. This is what the golf means. This is what gentlemen only, ladies forbidden. Thank you very much. We had a wonderful talk. We appreciated it. Thank you. And as a token of appreciation, we have a small memento to be handed over from Professor Srinivasan. Thank you. Please, all of you stay with one photograph.
Yeah, please join for that photo.
No, my permission always. Anything to do.